Mr. Speaker, honorable colleagues, I thank all of those of you who are still here this evening. I would like to talk to you about women, our mothers, our sisters, and our daughters. Those who raise children, those who care for loved ones, those who work, who undertake, who create, and who innovate. Of all the women in this country, more specifically, I want to talk to you about their health. Talking about women's health in Canada is not about addressing a marginal, sectoral, or identity issue. Nor is it a debate reserved for a few specialists. No. We're talking about half the population. It's about the strength of our families, participation in the labor market, productivity, and ultimately, our country's prosperity. As you know, I am not approaching this subject in an abstract way. For almost 30 years, I worked in a sector that directly affects women's lives. I listened to their stories, their pain, their concerns, their incomprehension in the face of a system that too often does not hear them or believe them. I myself experienced the ordeal of cancer, just as did my youngest daughter. And like so many other women in Canada, I saw firsthand how symptoms are trivialized, diagnoses are slow to come, and prevention is inadequate.
The journey of a woman, an entrepreneur, a mother, and an immigrant who holds the unwavering belief that women's health is not a cost, but a driver of equity, dignity, and prosperity for the entire country. Before I go any further, I wish to make it clear, this bill is not my bill. It does not belong to me. It was born out of conversations and lived experiences. It is the result of collective, patient, and often invisible work carried out over the years by clinicians, researchers, community organizations, committed companies, and most importantly, by women who had the courage to share the stories of their pain and suffering. I am simply carrying forward the torch that others have carried for far too long without being heard. The reality has been clear for years, and so have the needs. And yet, nothing has changed. This disconnect between what we know and what we are doing should concern us all. I am firmly of the belief that the Senate is precisely the place where these blind spots must be confronted directly, away from electoral cycles and partisan reflexes. Le problème fondamental auquel nous faisons
The fundamental problem we face and that no one is ultimately responsible for women's health in Canada. The current system is a patchwork of fragmented jurisdictions. Provinces deliver care, professional bodies regulate practitioners, and specialty companies set clinical standards. At the same time, universities train doctors and control research. Health Canada approves drugs, and the CIHR funds studies. I have this question for you. Who is accountable for the overall functioning of the system for patients? The answer is simple. No one. Everyone operates in silos. Strong political will is therefore needed to coordinate the entire system. And that is precisely the ambition of the national framework I am proposing. Before introducing this bill, I took the time to listen. I especially want to help the Women's Health Coalition, an organization that has been working tirelessly for more than 15 years to make women's health a priority across Canada. My office and I have been working closely with them for several months. The coalition brings together academics, clinicians, data experts, committed businesses, and community organizations from coast to coast, united by a common goal to make real progress in women's health. I've also spoken with more than 30 fellow senators, some 20 members of parliament, and ministers from across the political spectrum. I want to thank everyone who took the time to guide me on this bill, especially my team and the Library of Parliament, as well as all the translators. This allowed me to further my thinking, improve the text, and confirm what is obvious. Dear colleagues, inaction is no longer an option.
Stage. This bill does not create any new care program. It does not impose anything on the provinces and territories. It does not further medicalize women's lives. It does not target a particular disease. Its propositions stem from a different vision. It assigns the Minister of Health a specific duty to develop a national framework for women's health in collaboration with the Minister of Women and Gender Equality, other relevant ministers, the provinces and territories, Indigenous people, and let us not forget civil society organizations that work every day to advance this important cause. This approach is based on a clear choice, that of collaboration. Lasting improvement in women's health requires structured, ongoing, and shared coordination among all actors involved. That's precisely why this bill establishes concrete mechanisms for dialogue and follow-up. In particular, this bill requires the Minister of Health to convene at least one national conference, bringing together all relevant stakeholders to develop the framework. Subsequent conferences are to be held every 3 years to gather input, adjust priorities, and assess the effectiveness of the measures implemented over time. Cette coordination ne vaut que si elle s'accompagne d'une...
This coordination is only valid if it is accompanied by genuine accountability. Indeed, Parliament is not a mere observer. It is at the heart of the system. Unlike an administrative strategy initiated and monitored exclusively by a department, this national framework is subject to explicit parliamentary oversight. Thus, in the year following the law's entry into force, the Minister will have to submit a report to Parliament presenting the priorities selected and the implementation strategy for the national framework. 5 years later, a second report will have to assess its effectiveness, the progress made in research and innovation, and collaboration with the provinces and territories. The bill also provides for women's health to become a permanent item on the agenda of meetings of health ministers across the entire country. All of these obligations finally place women's health within a clear and transparent cycle of monitoring, evaluation, and parliamentary accountability. This is a far cry from a one-off, declaratory, or symbolic approach. In concrete terms, this bill is based on 4 complementary pillars: understanding, preventing, training, and coordinating. I will organize the rest of my remarks around those pillars. Let us be clear, colleagues. Canada is currently moving forward without a real compass when it comes to women's health. According to the Global Women's Health Index published by Hologic, Canada ranks 64th in the world. This is far behind several comparable countries. The United States ranks 38th, the United Kingdom 48th, and Germany 6th. It's worth mentioning that at the top of the rankings are Taiwan, Kuwait, and Austria. This result should be a wake-up call for all of us, dear colleagues. It reveals a worrying gap between the image we have of our healthcare system, universal, accessible, and fair, and the actual experience of many women in this country. This same observation was confirmed last November by the Standing Committee on Health in the other place. In its report entitled Women's Health in Canada, Closing the Gender Gap, the committee explicitly acknowledged that it had not addressed women's health for nearly 28 years. 28 years. This figure alone highlights an institutional void that can no longer be ignored. The last federal framework for women's health dates back to 1999. In addition to being heavily focused on reproductive health, it contained no measurable objectives, no monitoring mechanisms, and no accountability requirements to Parliament. This framework did not fail because of a lack of ideas. It failed because of a lack of structure.
À ce jour, les données sur la santé des femmes sont dispersées entre les provinces, les territoires, les organismes de recherche, les établissements de santé et les ministères. Elles ne sont pas harmonisées. Elles ne sont pas toujours comparables. Et elles ne fournissent pas une image nationale fiable. Sans données fiables, il devient impossible d'identifier clairement les inégalités,
their extent, track development, and most importantly, address the system's shortcomings. This fragmentation is also reflected in access to care. First, existing initiatives are too often focused on a specific moment in life, adolescence, pregnancy, or menopause, without providing a true continuum of care. Then, in rural, northern, and remote communities, access to services is limited by the scarcity of professionals, the large distances involved, and long wait times. These constraints lead to the late identification of diseases and incomplete care. Finally, as we all know, access issues disproportionately affect Indigenous, radicalized and immigrant women, along with women with disabilities, those who face linguistic, cultural, and physical barriers, and sometimes systemic discrimination. These inequalities do not simply add up. They are compounded. Mais toutes ces inégalités d'accès.
But all these inequalities in access reveal a broader problem: chronic underfunding of women's health research. In 2020, less than 5% of global research and development funding was devoted to women's health.
Cette part n'atteignait en...
In Canada, this share was still only 7% of federal funding in 2025. This is neither marginal, nor accidental, nor recent. Between 2009 and 2020, barely 6% of Canadian Institutes of Health Research funding was allocated to projects related to women's health, most often focused on cancer, of course. According to data from the Center for the Advancement of Research and Surgical Care at McGill University Health Center, research on endometriosis remains massively underfunded compared to other chronic conditions.
On estimait.
In 2022, it was estimated that approximately $4 per patient was invested annually in endometriosis research, compared to $31 per patient for diabetes and $130 for Crohn's disease. These figures point to a major gap: the absence of a national framework capable of setting clear and shared priorities for women's health. Underfunding is only part of the problem. Women also remain underrepresented in research itself.
Un exemple est particulièrement...
One example is particularly telling. 3/4 of people with multiple sclerosis are women. And yet, only a few hundred studies, about 350 out of more than 100,000, address issues specifically related to women's health. This knowledge gap is all the more alarming, given that chronic diseases affect women more than men. According to the Public Health Agency of Canada, among people aged 65 and up, osteoporosis is 196% more common in women, osteoarthritis 38% more common, and dementia 25% more common. Underrepresentation in research does not only affect women in general, it also affects some groups of women in particular in certain professional fields. I'm thinking especially of women in the armed forces, police and fire services, and even those in the sports sector where data on women's health is still very inadequate. As honorary captain in the Canadian Coast Guard and a lieutenant colonel in a reserve regiment, I am particularly sensitive to this issue. The available data suggest increased problems with personality disorders, sexually transmitted diseases, incontinence, urinary tract infections, and even infertility. This knowledge gap is not insignificant. It results in less appropriate treatments and poorer health outcomes for women.
Pattern can be seen in the field of cancer care, where the severity of gynecological cancers stands in stark contrast to the limited resources dedicated to them. For example, ovarian cancer research receives 5 times less funding than research on breast cancer, and half the funding allocated to prostate cancer research. Unsurprisingly, this lack of resources comes at a high price. The 5-year survival rate for ovarian cancer is 44%, barely half that of breast cancer, which stand at 89%. But research, essential as it is not enough. The knowledge produced must be translated into effective prevention. Early detection and clinical practices that truly reflect women's experiences. To understand is to recognize these facts. It means looking at the data as it is without complacency. But understanding is not enough either. We must act much earlier. And that is precisely the purpose of the second pillar of this bill, screening and prevention. La prévention et le dépistage.
Prevention and screening are among the most powerful tools for improving women's health in the long term. And yet, they are the ones we use the least effectively.
Qui fait défaut, c'est une mise en...
What is lacking is a structured and coordinated implementation of prevention and screening policies. Cervical cancer is a particularly telling example. It's one of the few cancers that can be detected before symptoms appear. It's largely preventable through vaccination against human papillomavirus. All provinces and territories offer school-based screening and vaccination programs, all of them. On paper, all the tools are in place. However, the results are not following suit. Vaccination rates vary from 68% in Ontario to 93% in Newfoundland and Labrador, depending on the jurisdiction, of course. This jeopardizes the goal of eliminating cervical cancer by 2040. The vaccine is available. It is effective, and it prevents approximately 95% of cervical cancers. So, how is it that there's been an increase in cases of cervical cancer after decades of decline, especially considering that it mainly affects women under 50? It is clear that this increase can be explained, among other factors, by a decline in participation in screening and vaccination programs. In fact, the figures for screening in general are very worrying. In Canada, only 15% of women have been screened for cancer in the last year. Fewer than 1 in 4 has been tested for diabetes. More than a third say they have foregone care for economic reasons. Breast cancer screening clearly illustrates this overall disorganization. On the one hand, I have to emphasize that Quebec has taken the initiative. Health services send a letter of invitation which serves as a prescription directly to women who are eligible. This best practice removes administrative and psychological barriers in one fell swoop. Patients do not have to take care of the process themselves. In other provinces and territories, the responsibility still rests entirely with the patient, who is asked to find out about the screening and take necessary steps, sometimes without even knowing she is at risk. Would it not be more appropriate to move from a system that waits for women to fall ill to one that reaches out to them systematically and proactively? Again, this isn't an issue of technology, but of organization, of coordination, and of political will. But prevention is not enough if, once in front of the doctor, a woman's voice is not heard. This is where our third pillar comes in. Better training and breaking with the all too frequent trivialization of women's pain. Understanding is essential. Prevention is indispensable. But between the production of knowledge and its practical application, there's a crucial link: training and clinical practices. It is precisely at this level that deep biases persist. They continue to influence in a very real way the way women are diagnosed and treated. These biases are neither anecdotal nor accidental. They're rooted in the very history of our healthcare system. This system has long been built around an implicit model, that of the male body as the standard of reference. As we can see, women's health has not been considered as such. It was added gradually through successive adjustments.
Treatment for women is not the same as treatment for men, and it shouldn't be. And yet, all too often, tools, protocols, and clinical reflexes are still based on male models. This reality begins as early as medical training. In Canadian medical schools, less than 10% of programs include content specific to women's health. The consequences of this lack of specific training are well documented. Take cardiovascular disease, for example. In women, symptoms are often less clear-cut, less typical, less spectacular. As a result, they are recognized much later. During a heart attack, only 29% of women receive an EKG within the recommended time frame, compared to 38% of men. Just 32% of women receive timely reperfusion therapy, compared to 59% of men. Moreover, early signs of heart attack are missed in 78% of women, delaying recognition and treatment. Canadian data shows that the in-hospital mortality rate following a heart attack is higher overall among women at 6.50% compared to men 4.24%. This phenomenon goes far beyond cardiovascular health. Today, nearly 70% of patients with so-called medically unexplained symptoms are women. For more than thousands of common conditions, women are diagnosed on average 3 years later than men. The results is years of unrecognized pain, years of doubting one's own body. And this bias becomes even more pronounced when it comes to diseases specific to the female body. Endometriosis is the most emblematic example. Listen to this. It takes an average of 7 to 10 years to get a diagnosis. According to EndoAct Canada, even after diagnosis, women wait between 6 to 18 months to see a specialist. And then another 6 to 24 months before surgery. This issue affects a significant part of the population, at least 1 in 10 women of childbearing age. Certain populations sont encore plus exposées.
Certain populations are even more at risk. Women living in rural or remote areas, Indigenous women, women from minority groups, and women on low incomes. The consequences of this lack of knowledge about the female body can also be seen in medical errors. When it comes to medication, women experience more adverse drug reactions and higher rates of hospitalization related to those effects. A study published in 2025 in the Journal of the European Society of Cardiology shows that beta blockers, widely used in the treatment of heart failure are less effective in women. They may even be associated with increased mortality. Another example. The dosage of zolpidem, a hypnotic, was not adjusted for women until 2013. That's 21 years after it was first put on the market. It's clear that this is all the result of a system that has long thought of health in masculine terms. Not to mention that women's health is still too often reduced to breasts and reproductive organs. This renders many conditions invisible, such as lipoedema, which affects almost exclusively women. I've personally experienced the disconnect between female physiology and certain medical treatments. A few years ago, my eldest daughter developed some worrying heart problems. She underwent a series of tests. A diagnosis was quickly made, heavy medication or even heart surgery. The whole family went through a great deal of anxiety. While searching for answers in Canada, in France, and in the United States, we discovered that the problem was not primarily a cardiac problem, but a hormonal one. A simple hormonal rebalancing made it possible to avoid heart surgery. This story is far from unique, and it clearly reveals a systemic problem. The female body is all too often studied in silos, with the heart on one side and hormones on the other.
Diagnosis or treatment. They extend into the very organization of care. A particularly revealing example concerns the way medical procedures are compensated. A 2023 study published in the Canadian Journal of Surgery shows that surgeons in 8 provinces and territories who primarily treat female patients are paid, on average, 28% less than those performing procedures of comparable complexity on men. For example, a hysterectomy is valued less than a prostatectomy, despite equivalent technical complexity. As a result, when procedures are undervalued, specialties become less attractive, volumes decrease, wait times lengthens, and the quality of care suffers. N'oublions pas par ailleurs que les déséquilibres ne concernent.
Let's not forget, moreover, that imbalances do not only affect physical health. Women are more affected by anxiety and depression. They are more exposed to physical, psychological, and sexual violence. This increases the risk of mental health problems. These are not individual weaknesses. They are structural mechanisms.
There is also a more subtle but equally significant phenomenon, the trivialization of women's pain. This is presented as an inevitable part of being a woman. Added to this are cultural and social factors that are often invisible. The relationship to the body, pain, and speech varies greatly depending on the context. In some cultures, pain is kept silent out of modesty. When speech does not circulate, the system cannot respond. Symptoms are minimized, diagnoses delayed, and inequalities widen. These mechanisms all have one thing in common. They are not due to a lack of goodwill. Far from it. Instead, they are due to a lack of training and understanding. When pain is trivialized, When cultural codes are not understood, the medical system misses the warning signs. It is precisely at this level that the training of professionals becomes a key lever for prevention. Colleagues, all these realities have a collective cost. Canadian women spend 24% more time than men in poor health or with varying degrees of disability. Training practitioners is therefore essential, not only medically, but also on human, cultural, and relational levels. This is one of the fundamental pillars of this bill. In light of this data, one question stands out. How can we remain deaf to such massive dissatisfaction expressed for so long by those who experience the system on a daily basis? Two separate surveys conducted by the Isaac Waltham Killam Foundation, better known as the IWK Foundation, and by the Maple Care telemedicine platform, converge on the same results. More than 3/4 of respondents feel that the current system does not meet their needs. Colleagues, when the majority of citizens clearly say, "This is not working for us," it is no longer a matter of individual discomfort. It is a wake-up call for public decision-makers. This is precisely where the federal government's role comes into its own, not to replace the provinces, but to do what no single level of government can accomplish alone. Provide consistency, harmonize data, link research, prevention, and care, ensure a fair pan-Canadian vision. This is exactly what this bill is about.
I also want to emphasize the economic cost of a system that does not give women's health the respect it is due. The World Economic Forum has shown that closing the gap could generate worldwide up to $1 trillion per year by 2040. Today, Canada faces a troubling paradox. Despite having a universal healthcare system and being a member of the G7, our country ranks among those where the economic cost of poor women's health is highest relative to projected GDP by 2040. In other words, we have the tools, but we are paying the price for inaction. For instance, the untreated effect of menopause alone are estimated to cost about $3.5 billion per year, according to the Menopause Foundation of Canada. This includes $237 million in lost productivity alone and nearly 540,000 workdays lost each year. Regarding endometriosis, and according to the organization EndoAct Canada, the costs of poor management are estimated at $2.5 billion per year in economic losses. Based on numbers from the World Economic Forum, addressing gaps and shortcomings in women's health could reduce the time women spend in poor health by nearly 2/3. Worldwide, this could add an average of 7 healthy days of life per woman each year. That amounts to a total of more than 500 days over the lifetime of a woman. According to the World Economic Forum again, this could also boost Canada's economy by $37 billion per year by 2040. And beyond the economic cost, there is a human cost, one that is endured by women across the country and far too often ignored. This is intolerable. Chers collègues, investir dans
Colleagues, investing in women's health does not mean increasing public spending. It means strengthening our families, our social fabric, and our economy. Canada sees itself and claims to be a leader in equity, equality, and diversity. Here is an opportunity to translate that ambition into concrete decisions. We must never forget that behind all these figures, there are real lives. There are women. Since this bill was tabled, many of them have written to us, describing difficult treatments, unbearable pain, and a deep sense of abandonment. Some describe procedures that were considered routine, but whose consequences have turned their lives upside down: chronic pain, loss of mobility, loss of intimacy, inability to work. In conclusion, honorable colleagues, Bill S-243 does not claim to solve everything. It proposes the conditions necessary to do better. Better because better is fairer. Better because it would be more rigorous. I invite you to support it, not out of partisan reflex or ideology, but because the status quo is no longer tenable. Before concluding, I would like to thank all those who, every day, advance women's health, sometimes behind the scenes, often without recognition. This bill owes them a great deal. I'll take a moment also to thank the women who testified, those who put into words pain that has long been ignored. It takes courage to say that something is not working, especially when we have too often been taught to remain silent. It is high time to finally send a clear message to all women. Colleagues, by supporting this bill and sending it as quickly as possible, we are simply saying simply but firmly to all those women, we see you, we hear you, and we are taking action for you. Thank you,